personally thank the faculty members for this day 2 program, Dr. Manish Arora, Mr. Ramakrishnan, Mr. Raj Kannan, and Mr. Deepak from Odisha. So before we start the program, just to have a general overview of what is the kind of population that we have. How many of the population here are doctors? Please raise your hands. Doctors. Good. Physiotherapist. Majority. Physical education teachers. Coaches. Good. All right, fine. Just one more question. How many of them understand Tamil? Okay. Bob, don't say that. Bob, you're from Uzbekistan. You have no idea about Tamil. All right. So we will be having it as a more an interactive session. It's not going to be theoretical or no kind of formal one. We want a lot of people to interact so that we learn together, and language should not be a barrier. You want to speak in Tamil? Please go ahead. You want to speak in English? Yes, go ahead. We are always there to help you, and make sure that we learn as much as possible. This day 2 program is going to be very interactive. So questions will be asked. Don't hesitate to answer. And if in case you're wrong, please don't worry about that. We'll take care of it. So without any delay, I'll request the first session to be started on basics of shoulder signs. I request Dr. David Rajan to chair the session. And I request Dr. Amit Joshi to join us on the dais for moderating the session.
Raj Kannan here? Raj, you are here? Raj Kannan? No? Okay. Mr. Ramakrishnan? Mr. Ramakrishnan is not here? Mr. Ramakrishnan? Oh, please come. Chair this session along with us. Come. So with me is Dr. Amit Joshi from Nepal. In this session we have shoulder and sports, a comprehensive review, anatomy and biomechanics in overhead sports by Dr. Manish Ashraf from Chennai, science behind shoulder imaging, what should we look for, by Dr. Jitsin Manna from Calcutta, and 6 scapula and kinetic chain, the basics of shoulder survival by Dr. Shyam Sundar. So after that we will have a good discussion. Let them finish the talk. I request Dr. Amit Joshi to call for the speakers.
May I request Dr. Munish to continue?
Good morning. Good morning, one and all, for the second day. I just want to know one more thing. How many players are here? Players, yeah. Volleyball, basketball? Seems like volleyball. What sport? Volleyball. Okay. Thanks. Okay. So, start the presentation. So, it's about anatomy and biomechanics of overhead athletes. Okay. I'll be covering the topic as who is an overhead athlete. What are the anatomy which person has to understand? What are the adaptations in an overhead athlete which happens over time? And what is the important biomechanics related to an overhead athlete? So we'll take an example of case study of a cricket player, Mr. Jasprit Bumrah. Is he currently active playing? No. there's a prize for the answers as well. What could be his current injury? And as per this is the latest newspaper report, what are the 5 biggest problems faced by Jasprit Bumrah? Currently, why is he out of action? Yeah, somebody can stand up, yeah. There's a special prize also. I
You
can
can-
hear,
your mic.
Mike.
yeah,
You
I can
come
hear
in
a
front.
lot of current problem.
Yeah, can you stand up? We can't see you. Can you go to the mic, please? Just behind you is the mic. Just behind you.
Yeah.
Probably stress.
Yeah, give us your name and tell us.
I'm Dr. R.V. Shankar. A stress fracture of the vertebra.
Yeah, that's one of the answers, but the current problem
I don't know.
is related to our topic today. Jasprit Bumrah எதனால இப்போ ஐபிஎல் விளையாடல? Why is he not in action? Related to today's topic, hint அதே தான். It's a shoulder problem. It's because he has a rotator cuff injury. So the biggest problems are the shoulder, which he is facing is shoulder, elbow, spine, the stress fracture which sir was talking about, abdomen and rib. I think Madam Sai Lakshmi, you can note sir's name because one of the correct answer was there. Okay, so we'll take this as a case study because all of the parts are involved. He's a fast bowler. Why would he need a rib fracture or an abdomen injury? So that is the core of today's topic, how a thrower or how an athlete can have all these kind of injuries. Even though he's not into boxing or contact sports, he's having abdomen injury. Why? So we'll look into that. So who exactly is an overhead athlete? It can be a bowler, it can be a swimmer, it can be a weightlifter, a javelin throw, it can be a tennis, it can be volleyball player or a basketball player. But there is a definition to an overhead athlete. It is the overhead motion is a intricate, highly coordinated musculoskeletal sequence, multi-direction, supraphysiological. So all high-five words are there. The word which we need to identify is supraphysiological. That means something above normal, supraphysiological. So are we human beings designed for this supraphysiological activity? If you see the similar species, other like ape, chimpanzee, they do not do overhead activity. But we have done it in the past, and that was, any guesses? பழைய காலத்தில் how did we do hunting? வேட்டையாடுறது. So this was, we used to hunt for food. So normally we used to throw the spear or something movement like a javelin. So we are actually designed for this, but in a particular limit, not beyond that limit. Beyond that limit something happened. So that is what we are going to look into. So before that, some basic anatomy. Shoulder anatomy is comprised of bones, muscles, ligaments and tissues. We have four muscles, that is the rotator cuff muscles. We have a capsule which keeps the humerus in place. And this is a video. Here we can see the muscle. This is called the infraspinatus. We are seeing from behind. We are seeing from behind. It helps in rotation. There's a teres minor. It helps in external rotation of the hand. So on to the right, what you're seeing is this video is the front of the hand. So much of muscle is there. This is called the subscapularis. It aids in internal rotation of the shoulder. So this is actual cadaveric view. And this is the side-on view of the superior muscle. It's called the supraspinatus, which helps in lifting up the shoulder. Okay. So these are the muscles around the shoulder. The next thing is what we have to see is how the shoulder joint is in place. That is with help of all these structures, namely bones, the glenoid and the humerus. This is for the physios, okay? Glenoid and the humerus, ligaments, the labrum and the capsule, the muscles we just now saw. So what are the ligaments involved in the stability of the shoulder joint is, out of all these ligaments, this is for the physios, I again repeat, okay? There are ligaments in front, there are ligaments behind, there are ligaments beneath. Out of all that, the inferior glenohumeral ligament, or the glenoid, the one which is beneath, okay, acts like a hammock, acts like a resting place for the head of the humerus to rest on it. So this is the important structure which provides stability, especially anterior and inferior stability. Okay. Now this is a video showing the capsuloligamentous complex. Can I get the sound on? Yeah. Can you hear the pop? Yeah, sound can be. Can you hear the pop? So this is the actual muscles are taken off. This is the bone and the capsule which is there attached. So every time we move, this capsule also moves. So you can see how much of force is actually required to tear this labrum or to tear this capsule for a shoulder joint to dislocate. So this is a suction effect produced by the labrum. This also contributes to stability. So stability is provided by the bones, the muscles and the capsule, and injury can happen at any levels. Okay, so at minimal loads, to summarize, at minimal loads the stability is provided by the suction effect. At moderate loads to the shoulder, it's the muscles which contribute. At large loads, it is the inferior glenohumeral ligaments. Large load meaning abduction and external rotation. At 90 degrees of abduction and external rotation, for a volleyball player cocking up to smash, it is going to be this ligament which is going to be maximally stretched. That is your IG, that is inferior glenohumeral ligament complex. Okay. So this is a brief anatomy. Now how does it adapt over time? Say a player has a career of, how long has it been since you started volleyball practice? Anybody? எவ்வளோ நாள் ஆச்சு, எவ்வளோ வருஷமாக விளையாடுறீங்க? Just சொல்லலாம், be free, be open. 5 years? More than 5 years, okay. So as a player starts, everybody is normal, till about 14 years we're all normal. Then we enter into sports. So a 10 years into practice, 20 years into practice, the shoulder adapts itself. It adapts very differently for each kind of player. So here we will see two different groups. One is left side, volleyball player. Right side, swimmer. Both have overhead activity. For both people, the shoulder will go above the head level. And in between you can keep basketball, shuttle, racket sports, everything comes in between. Now the movement on the left for a volleyball player is single time smash mostly. That is similar to a pistol gun shot. One time force event. So that is called ballistic force. That is at one point of time, ball is coming on top, he is going to put his extreme effort and then smash. So that is called a ballistic effort. Now imagine doing this again and again and again and again. At least 1,000 times in a month, million times in a year doing that. Now on the right side, swimmer. His is more repetitive. That is the same amount of force he is using every time. Same amount of force he is using. There is no forceful exertion movement. He is going to do the same amount of movement. So that is called a repetitive force. Now when a ballistic force or a repetitive force is being done over a long period of time, this is supraphysiological. This is, remember the definition I said, supraphysiological. So this is something above normal. So these kind of players will go in for an adaptation. What kind of adaptation? That is, the thrower or the volleyball player or the overhead athlete will have a decreased internal rotation. They will have increased external rotation, but the internal rotation will be less. So the coaches here need to identify that if there is a movement problem, that is normal for this person. Okay, they'll have increased external rotation but decreased internal rotation, and that is GIRD. These concepts will be explained further in the other talks. Okay, so they are more prone to specific lesions like slap and pulley lesions. This is for the physios. For the swimmer, on the other hand, repetitive movement, water polo, like that, those kind of games, they will have increase in movement. So they will have capsular laxity, that suction effect, that will become very loose. So they will have a different kind of problems. Okay, so essentially, whatever problem the overhead athlete face, it will be either a mobility problem or a stability problem. Mobility meaning movement will be reduced. Stability means because of the high movement it can dislocate. Either it will come in this spectrum only. Okay, so we need to diagnose where they stand. Okay, now biomechanics. Now biomechanics, the seminal paper or the important paper was proposed in 2003. Biomechanics by Ben Kibler. He is an orthopedic surgeon in the USA. Now he stated 3 things. Again, this biomechanics will be dealt in detail by the other talks. Okay, so I will just go kinetic chain. Kinetic chain means every movement is chain reaction. only shoulder is not moving. It is a chain reaction. From foot to shoulder, everything is going to move. This kinetic chain was proposed by Ben Kibler, and the importance was proposed by him. And he said it has three principles. One is optimized anatomy. You need good anatomy, good muscle strength. Next is that muscle has to produce force. So that is called sequential generation of force. Next is that muscle pattern, as in that force should travel in an efficient pattern. That is called efficient motor pattern. Okay, so this is ultimately the concept which he has said. Now I am coming to the end of the talk. Take home message. It is best summarized by our Nai Shegar Vadivelu meme. Okay, I'll tell you how. Building stronger, basement weak. நீங்கள் எவ்வளோ தான் ஷோல்டரை டெவலப் பண்ணாலும் if your core is weak, if your foot and lower limb is weak, you will perform well for a short period of time, but over time it is going to decrease. So building strong, basement weak, you have to keep it in mind, all the players. Okay, இன்னும் ப்ரொஃபஷ்னலாக டேக் ஹோம் மெசேஜ் சொல்லணுன்னா, ஃபஸ்ட் திங் வந்து either it is going to be a mobility problem for the coaches. ஒன்று ஷோல்டர் அதிகமாக மூவ் ஆகும், இல்லை கம்மியாக மூவ் ஆகும். அது நீங்கள் ஐடென்டிஃபை பண்ணணும். ரெண்டாவது ஃபிசியோஸ், யூ ஷுட் ஐடென்டிஃபை விச் மசில் குரூப் இஸ் அஃபெக்டட். எந்த மசில் வந்து சரியாக வேலை செய்யலை, எந்த மசில் வந்து கொஞ்சம் வீக்காக வேலை செய்யுதுன்றது யூ ஹாவ் டு ஐடென்டிஃபை பேஸ்ட் ஆன் த ஸ்போர்ட். த லாஸ்ட் திங் இஸ், எந்த செயின் மறந்தாலும் கைனட்டிக் செயின் மட்டும் மறந்துடாதீங்க. Because it starts from your foot and goes all the way there. So everything is connected. Okay. Thank you for this opportunity. Thank you Dr. David Rajan sir and Shyam sir and Santosh sir, entire team of Ortho-One for providing me this great platform.
Excellent, Manish. You put it simply so that everybody can understand. I'm sure they have a lot of take-home message. We'll have the questions in the end. Come and sit with us. Okay, I will call you towards the end so that you please be prepared to ask questions. You want to call the next?
May I call for the next talk, Dr. Jitson, please?
So, any questions you have, ஒரு பேப்பரில் எழுதி கொடுத்தீங்கனாலும் சரி, like be ready to ask. The mics are placed all over. Don't hesitate to ask questions. Introduce yourself and ask questions towards the end of this session. There are 2 more talks.
So, good morning everybody. It's a nice crowd on a nice morning. So today my talk will be on the science behind the shoulder imaging. Today we'll summarize this science behind the imaging into 3 basic questions. First, what should we look for when we are going to investigate as a physio or as a coach? And how to interpret. Now the last part is not very much important here, but what and when, these 2 things we have to understand. Now we discuss on some case scenarios. A 25-year-old male presenting with a painful overhead or the throwing activity. Similarly, a 75-year-old male presenting with some painful abduction while doing some activity, while playing golf or maybe something. So, are the pathologies the same in these 2 patients? Obviously no, because the one reason is that we have to understand that the age is an important pivotal role. For a 25-year-old playing athletes has a high chance of having a slap lesion causing a pain, whereas a 75-year-old person, golfer, painful abduction, high chance of impingement syndrome will be there. So to summarize this thing, shoulder pathologies, when we try to investigate, we have to put on some basic things. First, history is the most important part. Before doing or before jumping to some MRI evaluation, we have to take the history part very clearly. And shoulder pathologies are very much well related to the age, the spectrum of the range of motion. So we can identify which problem actually needs the investigation and which doesn't. So if we see that the age distribution, mostly overhead athletes of the young population have some atraumatic instability related pain or some other instability related pain at the early age. When you gradually shift from the early age towards these 40s or 50s, the frozen shoulder problem takes the upper hand. And when you shift more towards the 80s or the end of the person's activity life, then the periarthritis or the arthritis problem, they took upper hand over the shoulder. One thing we have to keep in the mind that all the patient aged person coming to physios having the shoulder problem, they are not frozen shoulder. Another important part, the spectrum of the pain. Not all the shoulder pain is the shoulder originated pain. There are some kind of spine problem which can mimic a shoulder pain, which is having the cervical radiculopathy which can mimic as a shoulder pain. So before jumping to some advice of investigation, we have to understand not that the important is the origin of the pain, not the location of the pain. So if we see some scenarios, an elderly patients having a pain over the deltoid insertion at the night, or having a pain at the bilateral shoulder while lying down, or having a young athlete having a pain while throwing. These three different scenarios has some different diagnosis. Having a deltoid insertion, we are much more prone towards the cuff tear. Having a bilateral shoulder pain is much towards the AC joint arthritis, and the young athlete is more prone to the slap lesion. Similarly, an elderly person having a current line sensation while taking his hand up for the elevation is more likely to be an impingement syndrome. So why this is important? If we analyze the spectrum of the range of motion, shoulder joint provides a 6 axis of motion. So when this 6 axis of motion is restricted, when you lose the rotation part of the motion, it becomes from the 6 axis to a 2 axis motion. And so when we lost the sidewise elevation, but the patient has a better rotation, then the high chance of impingement is there. And if we lost the rotation, but the elevation part is good reasonably, the high chance of adhesive capsulitis or frozen shoulder or arthritis is the important part. It can be happening. So if we focus over this flowchart, if the patient's having both active and passive restricted motion, then we have a high chance having a frozen shoulder. If the passive motion is good, but the active motion is restricted and painful, is more inclined to the cuff tear or AC joint arthritis. We have to understand one important point, that the range of motion apprehension is different from the pain. A person is complaining that I feel my shoulder is coming out of the joint. That is not a pain, that's apprehension. So it's more towards the instability, not the other pathologies. So if we have this passive function, good, painless, but active, restricted, high chance of cuff tear, we can advise the MRI or the USG. And if the patient has restricted both active and passive shoulder movement, then the high chance of frozen shoulder, mostly the diagnosis over the clinical part, or it's over the X-rays. So the modalities of the investigation, they are the X-ray, CT and USG, MRI. X-ray basically used for the post-traumatic injuries, and MRI, although very costly, it is mostly provides us the most of the informations. So in the X-rays, we can see there's some AC joint dislocations or the proximal humerus fractures, which can be easily identified. Jumping to the MRI, we have to understand how the machine works. MRI is a machine which provides you a magnetic field. The patient, when coming inside the gantry, we put some electric pulses. These electric pulses organize our body molecules in some certain sequences, and when the current is cut off, the connection, then again those molecules emit some energies and giving the images. This part is important because we are going to discuss why the good MRI scan is needed for a person, for a shoulder consultant to diagnose. Now, this is two different images. One is a 1.5 Tesla and is a 3 Tesla. Tesla is the parameter of the magnetic field of the MRI. So you can see that in these images, that part red circled is very faintly demarcated, very difficult to understand actually what is the pathology. But when we change into this 3 Tesla machine, we can see there is a clear-cut demarcation is there, is a labral injury. Similarly, if we see in this 1.5 Tesla image, we can see there is a very faint lesion, not very sure, maybe a tear, may not be a tear. When you shift to the 3 Tesla MRI, we can see that yes, it's intact, it's not very much torn there. So shoulder structures are essentially very small, they are very prone for diagnostic dilemma, symptoms are very much overlying. So we should always go forward to the higher able machine to get a good MRI pictures. Now, why we need a good interpreter or a good MRI person to investigate? Because, see, we can see this image is the anatomical labral tear, it's marked. Almost similar kind of image, same one sort of line going between the labrum and the bone. It is not at all a pathological. It's a sublabral lysis, which is a normal anatomical variation. So unless and until the person who is picking up those MRI scan or his analysis, then he is not good enough, he can always misdiagnose this thing to be a tear, and we may land up in a wrong surgery. Similarly, it's not also a tear, it's a Buford complex, it's a normal anatomical variation. So these points are very important, because when you are sending some person for the MRI, it should be a very standard center with a good radiologist who can give us the proper report. So a question to the audience: what do you like more, seeing a DVD, watching a DVD, or reading a book? I think exactly we'll incline for a more towards having a audio visual kind of presentation of everything. So it's same to us also. When we read one MRI scan, we are very comfortable to seeing all the images stacked in a DVD, and we are rolling down with the computer images, than reading a single film. Because when the radiologist or someone is picking the films, they are very choosy, they may miss something which is important to us. So similarly, if we think, if we don't have all the pieces, we cannot completely reconstruct the whole images. So until and unless we don't have all the images, we cannot recreate the whole pathology in our mind. So we cannot diagnose. So always when you are referring one patient, please send the DVDs with them, essential if we have, than having a normal MRI cuts over the film. So these are some images, we call it the coronal images for the MRI. The structures are identified, the supraspinatus, infraspinatus, labrum, various structures can be identified in various images. Those are known as axial images on my left, and right side the sagittal images, which shows different pathologies. Now, why this talk is important? Because in CCOT journal, in Orthopedic Journal 2013, one big, very important article published that what is the percentage of wrongly advised MRI scan we normally get. So we can, the result was very shocking, that 56% of the MRI scan for the shoulder pathology was ordered inappropriately, without any kind of pathology. So, and when the MRI was advised by a shoulder consultant, the accuracy level got up from 56 to 70%. And the last part, and very important part, from this whole group, if we remove the shoulder consultant and keep only basic doctors or physiotherapists or normal orthopedic surgeon, the margin and error even goes high up to 63%. So why this is important? Always when we are going to some dilemma of shoulder, which is very, very common. Shoulder symptoms are very overlapping. The MRI, the symptoms are very much overlapping. So when we are some kind of diagnostic dilemma, we should follow this triage. This is very important for the physios. When we have some patient with a shoulder problem, we should assess the problem first. And if we see there's a red flag sign, patient cannot elevate his hand, it's a completely paralysis, or showing the shoulder is coming out all the sessions, so it's a red flag sign. And if some specific shoulder problem, which we can understand is not going to improve by the physiotherapy, immediately we should send the person to the shoulder consultant for the further evaluation. And if we can see there is some non-specific shoulder pain which can be improved by the desensitization, we should go for it. So there is some clear boundaries when we should refer the patient to participant consultant and when we should manage by ourselves. If we take a simple example, many of the patients with the frozen shoulder presents us with the MRI having a partial rotator cuff tear, which is completely asymptomatic, doesn't cause a problem. Patient's problem is not at all related to it. But what we do, some of them has some other advice from some other doctor, okay, you need to go for surgery. So when this kind of some dilemma comes into the things, we don't trust our clinical test, because shoulder is frozen, we cannot do the clinical test, the MRI is not very clear. Immediately refer the patient to the corresponding shoulder consultant as per the triage, label it as a red flag sign, and let the patient be taken care by the corresponding consultant. So our take-home message from this talk is three. A country like India, where a lot of burdens of work is there, where the economic status is very much compromised to the normal person, we must be very selective and we must be very accurate. So we must follow the triage before doing or advising any patients, or we should follow the proper protocol to sending a patient to a corresponding shoulder consultant. Whenever we are advising any investigation in any scenarios, it must be very appropriate. A patient who can be benefited by a simple X-ray, we should not advise an MRI scan. And the patient who require MRI scan, that MRI scan should be of good quality. It should be from standard center which can interpret it better, and all the cuts, DVDs, it must be there to get a better interpretation. Thank you very much.
Thank you very much, Dr. Jitson. It was elegant talk. May I now invite Dr. Syam Sundar for his talk.
Good morning all. I'll be talking about the chain, the kinetic chain, not a key chain, not a locking chain, and we don't know what is the chain, all right? And about scapular dyskinesia. Now, the term of kinetic chain is used for all the description of how to move the body. The structural alignment is known as alignment, and when it works, it acts as an optimal control, distributes force appropriately, no excessive compression, transitory force, shear compression, kinetic chain, dynamic joint mobilization, neuromuscular control, blah, 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 blah. Do you guys understand what I'm speaking? Okay, let's explain this concept in a simple, elegant, understandable manner, all right? So this is nothing but a chain which connects your foot to your finger, all right? It needs absolute coordination between different parts of your body, and everything should work in tandem. Now the kinetic chain has a good coordination between the foot and ankle, the knee joint, hip joint, SI joint, thoracolumbar spine, cervical spine, including your brain. That's also very important, all right? It is a fine element of balance, focus, flexibility. Let me repeat once again. You have to think about balance in your athlete. Check whether your athlete is focused and whether he has the appropriate flexibility to get the component which Munish had explained, supra-physiological. That is more important. If you want your athlete to be supra-physiological, these three components are absolutely must. All right. Now, let's see. We always consider, or we always take an example of our precursors. Look at this video. Beautiful balance. Look at the spine, the back of the cheetah. Well balanced. The four legs, the front two legs for landing, and the back two legs for the beautiful thrust. Look at the tail, guiding the balance. The most important thing that you're going to see right now is how it's guiding itself to get the focus and get its prey. Apart from that, the most important thing that you're going to see right now, stable head, stable cervical spine. Look at the focus, absolute thrust, getting what it's needed with fantastic performance. That's why we say animals are much better to push supra-physiological compared to humans, and we have to follow the same criteria in getting our animals, our athletes to the animals, and they have to make sure they reach that kind of an attitude to get what they need in performance. Let's get into our own Taladoni. What has happened?
Almost hits it off the back foot, as we've seen MS Dhoni throughout his career.
Look at the balance
Commentators curse for
and
Carl
the force
Evans.
transfer from
The
his
last ball sails to
legs
six,
to the
as you
hips
say.
onto his bat. So this is what has been reciprocated up to his performance. Not just cricket. Look at the thrust for this long jumper. Get it on the hamstrings, quads, beautiful fly, excellent arm movement, free arm movement, safe landing, and get the best follow through. This is what is called as kinetic chain, which means every part of your body works in tandem, and you have to get that right. Now let's move on to the best video here. Roberto Carlos gets a magical goal. And how did that happen? Take a look at that. It's not the goal that matters. It's his positioning and how he positioned himself and how he got the follow through. Because if you do not have a good follow through, in spite of the good goal, you will end up with a very bad injury either to your hamstrings or to your core. Look at Roberto Carlos swinging himself mid-air just to make sure he maintains the balance. Look at this. These are all the injury prevention strategy which has been taught to him to prevent the injury. The goal may be good, but he should not suffer any injury. That's very important. So we as a coach, as a physical education teacher, make sure the performance is better. At the same time, the athlete is prevented. Now let's focus on upper limb kinematics. We know what is the importance of lower limb. Upper limb. Look at the volleyball player. Jumps, good quads, good abs, beautiful spike. This is what is needed. Alright? That's what is called in volleyball as ta-ta-ta. I'll explain to you. Look at this once again. Good push, good core contraction, excellent arm movement, excellent shoulder movement to get the focus. Now, this is what is called as ta-ta-ta. Is anyone aware of ta-ta-ta in volleyball? I'm sure Mr. Vipin is very much aware of it. Anybody? You know? Alright, fine. This is a very important thing which I came to know about in volleyball. Look at this. It's nothing but the footstep that you keep to generate the force in your glutes, push up and get that necessary height for an efficient spiking. Alright? Now this step which he's going to keep, first one is ta. This is the first step, ta. This is the second step, ta, a short one. This is ta.
Now.
This one.
Exactly.
And the longer one which is going to give him the thrust is ta, which makes him elevate, climb up and give the necessary height for an efficient spiking. So all part of his body is working in tandem to get it right. Alright? This is the biomechanics of spiking and you have to follow ta-ta-ta. How is the chain broken? Now this is the most important thing. Gluteus dysfunction, the first culprit. Because we always focus on shoulder strengthening, we forget the gluteus. That causes breakage of the chain, so he will not get the ta. Alright? Second thing is core dysfunction. The abs doesn't work. You're not going to get it. You're not getting the rotation in your trunk to get the spike right. And most important thing is scapular dysfunction. And now I come to the concept of scapular dyskinesis. Scapular dyskinesis is nothing but loss of control of the muscle which determines the movement of your scapula, the shoulder blade. If the shoulder blade does not move and if its movement is not controlled by the muscle, then you develop scapular dyskinesis. The shoulder will not function properly and all the injury will be quantitatively segregated to the shoulder or to the elbow. So the scapula becomes the culprit and we have to find it out. How to find it out? Now we have to ask the patient to undress. Look at his back. Look at this patient's left scapula. Just protruding out. Is everyone able to make it out? Left scapula protruding out, which means the muscle is not controlling the movement appropriately. And this is called sick scapula. You have to find it out, and if you find this out in your athlete, correct it at the earliest moment that is possible because you are preventing him from suffering any injury during his activity. So, in simple words, find out the abnormal movement of the sick scapula, fix it with appropriate exercises and stretching, you will prevent him from injuries. And as a result of which, your athlete will have the best smash. Not only preventing them from injury, giving them appropriate training. The right posture, right balance, right focus, and get the output right. Now, is the kinetic chain restricted only to your body? The next question. Are we restricting the kinetic chain only to the body? No, absolutely not. Have a look at this video. Sharapova. Sharapova's kinetic chain is howling. That is her kinetic chain. If you tell her to stop howling, she will not perform better. She generates her force by howling, which means for her, the kinetic chain actually starts from the ankle, hip, core, shoulder, and it ends by howling. If she doesn't scream, her serve will become defective. So that's a very integral part of hers. So it's not just the body, it's a mind which is also connected to the kinetic chain. Alright? So the chain is present everywhere. it is including in your wife. The only problem is the wife doesn't care about the balance. She cares only about the focus, and which we call as non-athletic chain, like this. It's just a focus and kind of chain, on a lighter note. So always try not to forget the balance, the focus, and the flexibility. Thank you.
Thanks, Shyam. Excellent. Please come and sit here. I'm sure everybody understood about kinetic chain, and all the three talks are over. And Jitsen, where is Jitsen? And Moniz, okay, sit wherever you are. And Ram, would you like to say something about the talks, or you want to call for discussion? Yeah. Yeah, there's a phone.
Hello everybody, good morning. I think Dr. Shyam Sundar spoke very well about the kinetic chain, and I think in my talk in the evening post lunch I'll be discussing how that is used for workout, because most of the trainers, when you work out, we don't focus on the kinetic chain alignment, and when that gets affected, that's when the injury happens. And thank you for starting on that, because the rest of the talks will be a continuing of that, and it was a great talk.
Yeah, the basic fundamentals you must have gathered from the previous three talks. Please do ask questions, and if you have any doubts. Any volleyball coaches here? Babur is a sports medicine surgeon from Uzbekistan. Yeah. Now, anybody else want to speak? Please, there are several mics at the back.
Vanakkam. Sham, I have a question for you. It is clear that not all patients need an orthopedic surgeon. And many shoulder problems can be solved with the help of the physiotherapist. So for trainers, what is the point? What is the point they should pay attention to in order to decide? Send patient to physiotherapist or to orthopedic surgeon?
The most important part of a physical education trainer or a coach is that they are in the first line of management. They are in close contact with the athlete, so they have got something called an advantage over time. So which means they are trying to prevent the athlete from re-injuring, because they can shorten the time of injury prevention, in fact. So try to identify what are all the predisposing factors, the risk factors. A trainer should first check whether the athlete is having a perfect balance in whatever sport he is involved in. For example, volleyball, is he having a good jump? Is he having a good landing? Or is he having a good follow through? If he has any of these things which is mismatching, then you should have an element of doubt that he is going to injure in some way or the other that is possible. Second thing is, as far as overhead is concerned, okay, presence of stiffness or restriction in movement, which we call as GERD, that is internal rotation is less, then high chances of overhead injury. And in knee, when an athlete is landing, something like this, you see a volleyball player, when he lands cross knee, very high chance for a knee injury, okay? So there are various other factors which are available to make sure that you identify these problems in your athlete and treat it appropriately. Now, when to approach or when to refer to a physiotherapist or a doctor, that's the most important thing. When you feel that you are incapable of diagnosing the problem, or in spite of all your valiant measures to make sure that your athlete is pain-free and still he continues to have problem and not able to perform up to the level, I would sincerely advise to get the opinion of the sports medicine specialist to sort it out at the earliest time that's possible, because time is essence for an athlete.
Sathak, one second. Let's see. How many MPT students are there? Master Physical Education. Physiotherapy, and then Master Physical Education also. How many are there? Now, please don't hesitate to ask questions. And think, you want to ask a question? Well, before that, Dr. Sarthak is going to ask a question. Sarthak, yes. Dr. Sarthak Patnaik, been our fellow earlier, and now he's a sports medicine surgeon from Bhubaneswar. Yes. And the Fenzine magazine, which you see, belongs to, that's his brainchild. Thanks, Sarthak, for coming.
Thank you, sir. So my question is very simple, sir, but it's a bit complicated. Like we know, as an orthopedic surgeon, we volleyball players or cricketers or even basketball players, mostly volleyball players, they come with a pain in the shoulder joint. And when we say it's most anterior, and when we do a clinical examination, we know that it is something like a slap lesion. Slap lesion is the labral pathology which causes pain here. So now, as we know, this is mostly due to the taut biceps exercise, and when they do in the pre-session, and the overhead force. So I want to know, is there a specific way a patient or a player can do a bicep exercise without damaging his slap to the physiotherapist or the experts? Like we all know, lifting weight can cause, because most of the injury takes place during exercise. Is there a specific way we can do a biceps muscle exercise which won't cause a slap? The technique.
I'm Ram Krishna. I'm an exercise expert, so I think I can answer for that. See, because being a unilateral workout or isolation workout, there is a lot of strain in the joint anyway. You cannot avoid that. And being shoulder being the stabilizing, because for any shoulder movement, the scapula has to be stabilized. And when the scapula is stabilized, that's where you can reduce the strain on the exercise. So before starting any workout, I would always suggest the trainers or physios to work on the scapula. Work on the scapula stabilization and then go for the exercise. That will, because it's a biceps, two heads. So there is always going to be pull and strain on the thing. So workouts like preacher curl, where you are stabilizing your joint and working on it, it's going to be helpful. And it's also the equipment which we use. The same biceps curl, whether you're working on your dumbbell, barbell, or a cable, will give you a different loading. So it's all about load management. So if you learn how to do a load management where you work according to the capabilities of an individual, then you can reduce the incidence of injury. I would say if any trainer says they will never cause any injury, he or she is lying. You can never avoid 100% injury in a sport or in a workout. What you need to do is reduce the incidence of the injury. And that could be done, I think in my talk I would say your proximal stability will lead to distal mobility. So if you work on your proximal stability, then it will help you out on your distal mobility, like biceps movement and exercise. I guess that.
Can you just show me how to do a biceps strengthening exercises while sitting and sitting or standing, so for the players and the coaches?
Okay, that was okay. Cool.
Suppose now you're carrying a dumbbell.
I can do it in my hand.
Yeah.
So in case of biceps exercise, it depends on where your arm is placed. Most of the trainers, what they do is they put it behind. You need to avoid. It's a simple thing, your shirt crease line, right? You keep that as a marker and you keep your elbow slightly forward. And this has been taught to me when I was training with one MRF Pace Foundation. There what happened is many of the Australian physios or Indian physios, what we used to do is we'll do full range of motion. To work on biceps, you don't need to work on total range of motion. This is your 90 degrees. And this is your, just above 90 degrees, you can work around this. Beyond this is going to work on your coracobrachialis, mostly the load will come. So I would just suggest work in this range is more than enough if your goal is to work on your biceps. When you go full range, it puts strains on the joint. The proximal stability gets affected. So you don't need to work on a full range if you want to load biceps. And the tempo of the workout is very, very important. FIT principle we have discussed, we have heard about FIT principle, frequency, intensity, time and type. But what people don't add is there is another TNR, fitter principle, the tempo and recovery between each. If you focus on that, the incidence of injury will come out. So whatever workout you do, whether it's preacher, dumbbell, barbell, alternate inclined curl, whichever, there are like 8 different or 10 different varieties of biceps workout, depend on the equipment, even if you do push-ups as well. Whatever you do, your tempo is what matters. And that tempo will control whether your load management is happening, whether there's an injury which is happening or not.
My last thing, do you think the position of the shoulder or the arm will help? Because what I train, I ask them to take support of their thigh, keep it like this, and then try to go with, not exactly like this, but this movement.
Exactly. What you are doing is a concentration curl. That's a workout which we train for bodybuilders as well. Because for athletes, and I don't usually give concentration curl, because see, none of the sports are played sitting, right? So why do we give sitting workouts? So if it's a bodybuilder where you're working only on positioning and posing, then you can give a concentration curl, which you were saying. You stand like this, your back straight. You don't keep your elbow actually on the thigh. You keep it on the side and you work in the tempo like this.
Yeah.
Slow, 2:3 tempo, where 2 seconds for concentric and 3 seconds for eccentric. And one thing all the trainers need to know is, if you want higher force production, eccentric phase is where you got to focus upon. But when you do a higher force production, there is a higher chance of injury also happening.
Yeah.
So what do we do? It's like, catch-22 situation. So how do you work around that? That's what it is needed. So bottom line, you understand your client's capability first and goal and work around that.
Yeah.
Right?
Thank you.
Thank you.
Excellent, Ram. A very good contribution from you. And is Raj Kannan or Manish, do you have anything more to add, anything different to add to what he said? The same thing, doesn't matter. Anything more, please? Raj. That's the Raj Kannan.
Yeah, that was a good point, because more and more people are playing sports, so more and more injuries are happening. Obviously, slap and bicep tear is one of the common things that we encounter often. To answer your question, when there is a pain going on, see, pain means what? There's an inflammation going on. So when there is an inflammation, by the way, you need to advise your patients to let the fire get doused. When the pain is 7/8, 7/10 or 8/10, there is no point in strengthening the muscle, because the muscle will make this further angry. So the pain scale must be the guide for you. If the pain is like 10 or 2/10, and every exercise you do, the pain should not get worse the next day morning. When they wake up, because the inflammation will set in the night. When they wake up in the morning, you know what you did yesterday was right or wrong. Okay, so the pain should not aggravate with any form of exercise. So sir was saying various types of biceps curl, fair enough. Mechanically speaking, if you do the exercise in short lever, the stress to the slab, the labrum is less. If you do anything in long lever, there are some biceps workouts they do like this, that are do this way, so that directly strain the slab. So short lever you can do, but go by the pain thing. Okay.
Right, thank you. Jefferson, you have a question. Anybody else have a question? Please come to the mic, and so that there will be a lot of interaction. Want some contribution from coaches, athlete trainer? There are quite a number of people there. The Rakesh, Shankar, Sivakumar. Please don't hesitate to ask questions. Yes, Jefferson.
Yeah, sir. My question is to the radiologist, and he was speaking about the shoulder slices in MRI. And can it be appropriate if an MRI, when it is prescribed, and I write neck cervical screening also? And do you have any strongly scientific studies that shows a correlation between the neck and shoulder, the percentage or quantification of the pain from the neck and pain? For example, the cervical spondylosis is contributing to close to 40% of the pain, and the remaining 60% is from the shoulder. And can it be read out in an MRI with neck screenings?
The thing is that, yes, definitely. But all the time, I should say that cervical screening is not essential in all the shoulder pathology. That's why I am pointing it out repeatedly. The history and clinical examination part is always the upper hand. See, a patient's having a let's say trapezitis, very common problem. This patient pain coming from the this back and it's coming all along the upper limb, maybe up to this elbow. So if we can identify it, but the patient, you can see that patient trapezitis, they have a fairly good range of motion of the shoulder. So a patient's having a good range of motion of the shoulder, not having a problem doing any shoulder related problem, but the pain is going through the shoulder, it's unlikely to have any shoulder pathology. So it's better not to do jump over the shoulder MRI scan because it will often come normal study and the money is lost there. So coming to the next question, yeah, there is statistics are present. How much is there? They have said that close to 40 to 45% of all the pathologies which goes through the shoulder, not originating through the shoulder. So we should be very much, clinically sound before advising a person or of an athlete or a person before advising an MRI scan, because it can waste money a lot. Yeah.
Okay.
Yeah, I think the message is you got to be very discreet about MRI. It should be sent to the right place and interpreted properly. Otherwise, it leads to unnecessary, unwanted surgery as well as treatment. I want a lot of participation from coaches. It's Mr. Suva, Mr. Vinu, basketball coach, right? You want to ask
Hello.
anything? Please don't hesitate.
My
The
name is
shoulder
Shivakumar.
kinetic change and everything you understood. You want to ask anything?
Yeah. My name is Shivakumar, playing tennis for 30 years, and I'm doing coaching also. Wear and tear of shoulders, say, because I know I just played. Now I can't able to work out my shoulders longer. How the age factor is, how the age factor comes, the youngsters and veterans. You want to know?
Your question is
wear and tear.
You are not able to perform how you were performing before. Adha munadi perform பண்ண இப்ப பண்ண முடியல. That's definitely possible. That happens for everybody.
Okay. How to improve? Suppose.
Correct. That's a very interesting question, because everybody ages, and definitely your muscles, capsules, bones ellame starts wearing out. But the question is, what steps we are taking to delay the wear? It will definitely wear out. There's no doubt in it.
Correct.
That's where the concept of conditioning, training, workout, stretches, everything plays a very important role. If you start playing without a proper conditioning exercises and muscle coordination, the wear out will be faster, which means the more you play, the more you're going to damage it. So that's where the responsibility of a coach is very important, to make sure that the athlete does adequate warm up, adequate conditioning, and then after he plays or finishes the game, adequate cool down is done. Now, if it is done over a period of time on a regular basis, then wear out can be delayed, and there is no way possible that you can prevent a wear out. It will happen, but you can delay it. As far as elderly is concerned, that's the best strategy, I would say.
Right. Thank you.
Vipin, during your time, was much importance given to the kinetic chain of shoulder? Were you aware of it? Can somebody give the mic to Mr. Vipin Vijay?
Back in the day, 90s, when we were growing up, the kinetic chain was not so important. We were basic, stretching was there, basic warming up was there, cooling down was there, thrust on knee problems, because back in the knee and our knee is the biggest injury breaker when it comes to basketball. So we given training on that for specific muscles and those, but kinetic was never given, and we never heard of it back in the day.
Okay. Siva, Mr. Siva, coach of Southern Railway. Sir, எங்க இருக்கீங்க? நீங்க kinetic chain importance கொடுக்குறீங்களா? Are you aware of this concept of kinetic chain in a basketball player, for example?
So in the past time, 20 years back I am talking, we are not, coaches not aware of physiotherapy. It's a big mistake we did in the past time. Now we got a lot of our Ortho-One got a lot of interactions with the coaches and players also. We are not using very much physiotherapy. Still nowadays also, I am coaching for the one engineering college now. The players, they'll come, we'll say 4:30, they'll come 5 o'clock. Immediately they'll start the workout, not they do warm-upping exercise and stretching exercise. This cause lot of heavy injuries nowadays. Coaches must aware of doing physio and warm-upping exercise and everything. In past time, we got lot of injuries made because of lack of awareness of physiotherapy.
Nowadays, are there any physio for example, railway team? Do you have a physio who can do all these things for you?
No, we are learning and we are teaching, sir, nowadays.
Employ பண்றாங்களா? Are you having a physiotherapist for?
No, college level they are not doing, sir. In college only physical directors they'll guide and they'll do, but not in separate physiotherapists there.
When I just want, we'll get to another. Yes, sir.
So myself Rakesh, I'm a football coach, especially into goalkeeping. So you showed a video of this volleyball, swimming, everything, but I especially understood. But here we are facing is like it's a different, totally a different kind of multiple injuries, because you know that. So the landing, the diving, and our kids, means I am especially coaching like under 16, under 18. So here they are facing multiple type of injuries, because you said that for volleyball this kind of injuries, for swimming this kind of injuries. But you can see that especially when it comes to football, because of landing, we will be facing multiple types of injuries. And another thing is like the recovery period, because we are facing tough challenge with the recovery period, because sometimes it takes 30 days, sometimes it takes 45 days, but we cannot able to find the exact, because since I am into coaching, we can able to find the exact solution. If they go to physiotherapist also, they are not providing us with the proper recovery time period. So there we are facing biggest challenge to provide the instructions or provide a better idea for the kids, and this is my major concern for our.
I'll take the question. Right. First thing is, before I answer your question, are you teaching your players on the concept of safe landing?
Yes, exactly.
Yeah, that's very important. So when you are teaching them on the concept of safe landing, then you should be able to understand or teach them on injury prevention. Okay, but still, football is a contact sport. The injury, very difficult to prevent it, but we are doing all the measures to prevent it. But the problem is, we already have a talk on on-field injury management in this one, which will answer all your question. So don't worry about it.
No, thank you.
Vinay, the last question for this session, please.
My question is to Dr. Jitsen. This is for the public interest that I am asking. I practice in Bangalore. Some patients come and ask me, when I advise them an MRI, they tell me that, doctor, I got an MRI of the spine 6 months back. Now you are advising another MRI for my shoulder. Will that not cause any harm to my body? Will that not be too much radiation? Can you throw light on that? Will the MRIs do any harm to the patient's body, or a repeated MRI cause any change to the body?
No, absolutely not. Because if we see, we have discussed a very basics of the MRI, because there's no scope to discuss in details. It's nothing but your body is placed in a magnetic field, and we are pushing some currents through the body. Your body molecules absorb some energy, emits the energy, and get the image. So there is nothing like a radiation. We often we mix this thing up. X-ray, CT, MRI. Yeah, X-ray, CT scan, they have some radiation effects. Definitely, if we do repeatedly in a short interval, there must be some residual effects. But MRI is completely harmless, and there is absolutely no cumulative effect in the body if we do a repeat MRI after 6 months. I think.
Thank you.
I'd just like to add one point for trainers and physios. When you handle athletes or any sport, first understand the movements involved in that sport. Because most of the physios and trainers, what we are doing is, without having the knowledge about the sport and what movement are having, because each sports have got different movement, and those movement are causing the injuries, or involved in those sports. So first understand the movement and then get into the diagnosis. So what you need is a differential diagnosis, and then work around it.
That's true with even doctors. Doctors who practice sports medicine also should be aware of the game, about the movements also. So thank you very much, Ram. Thank you, Amit. Over to Shyam.
So with this, we finish the first session, which is on basics behind the shoulder.